Good morning. My name is Adrienne Gray, and I'm presenting two practice change recommendations that will reduce the level of venous thromboembolism at the Martinsburg VA Medical Center. Let's go over what a venous thromboembolism is. Venous thromboembolism, otherwise known as VTE, includes a diagnosis of DVT, or deep vein thrombosis, and PE, which is a pulmonary embolism. A DVT normally forms in the large veins of the lower extremities, but can also occur in the upper extremities, which can block blood flow coming from the extremity. Over the long term, DVT can resolve on its own, but it can also cause post-thrombotic syndrome, which includes limb heaviness, swelling, pain, paresthesia, and ulcerations, which can become chronic. When a DVT becomes mobile, it can become lodged in the lung, which is a PE. Symptoms include hypoxemia, cardiac ischemia, systemic hypotension, and potentially cardiac arrest. According to the CDC, there are between 600 to 900,000 patients in the United States that develop VTE. Of these, 100 to 300,000 die as a result. Over one-half of the total number happens after surgery, and many don't occur until after they are discharged home. The cost for VTE is high. The direct associated cost of VTE across the country is around $10 billion per year. Sadly, this cost is not necessary and is preventable. Per patient, the cost is between $12,000 and $15,000 for a patient with VTE who do not experience complications. Per patient, the cost is between $12,000 and $15,000 for patients with VTE who do not experience complications. For those with complications, the cost can rise to as much as $23,000 per patient. Treatments of the disorders commonly uses anticoagulants, which can result in a 1% to a 1.4% chance of major bleeding that requires hospitalization and can cost as much as $22,000 just for the heavy bleeding treatment alone. The reason for this presentation is this. Martinsburg VA-MC has twice the national VA average of VTE cases perioperatively during an OIG inspection that occurred between October 1st, 2015 and June 30th, 2017. While current practices will need to be evaluated to determine if there are anything that can be changed, there are practice changes that can be made to lower the occurrence of VTE at Martinsburg VA. The first practice change is about resolving vitamin D deficiencies in patients who are seeking surgery. This includes testing patients pre- and post-operatively, as well as administering vitamin D pre- and post-operatively. The second practice change is to improve the education that is being given to patients. The education should be multidisciplinary and multimodal in how it is provided to patients. Education should be individualized to how the patient best learns new material. Now let's take a look at how vitamin D affects VTE rates. Vitamin D has been researched multiple times in regards to cardiovascular health and how it affects VTE. It has been found that vitamin D has anticoagulant properties. Wu and He state that vitamin D receptors may be important in thrombogenesis. Low levels of vitamin D are linked to cardiovascular disease and mortality, as well as linked to DVT formation and the formation of ischemic stroke. Spinal cord injury patients are especially at risk of lowered vitamin D levels, potentially because of the lack of sunlight exposure. According to the study by Ehigian et al., vitamin D levels for these patients are quite lower than in other studies of other groups of patients. This should be of particular importance to any VA facility due to the incidence of spinal cord injuries in our patients. In the study that we're going to look at by Wu and He in 2018, stroke was linked to DVT and to low vitamin D levels In their study, they used 180 eligible patients with stroke, 26% of which had DVT within 3 weeks. As previously stated, patients who have experienced stroke were also evaluated for DVT and vitamin D level. This is important because the difference between formation of a clot in the brain and a clot in the leg is just a matter of location. 180 patients were included in the study. Of these, 47 had DVT within 3 weeks of the stroke event. Vitamin D levels in all 180 patients was 56, was the mean level. The mean vitamin D levels for normal patients was 65. Vitamin D levels for stroke patients without a DVT is 58, and for those with DVT is 49. In the study of spinal cord injury patients by Ezanian et al., vitamin D levels were much lower. 80% of the patients in this study had vitamin D levels under 30 nanograms per milliliter. In the group that had levels higher than 30, the number of VTE is 9%. In the group that had levels lower than 30, the VTE incidence is 19%. Then in the same study, patients were either administered vitamin D or not in the different categories. In the group with levels higher than 30, those who were supplemented with vitamin D showed 0 incidence of VTE, whereas those who were not supplemented vitamin D had 11% incidence of VTE. In the category of patients with levels lower than 30, supplementation of vitamin D showed 2% incidence of VTE, and while not supplementing vitamin D, had a 24% incidence of VTE. Now we move on to how changes in education can improve incidence of VTE. Of course, we all know that education is important for patients, but how much more important is education on a potentially life-threatening outcome after a surgery that will require prevention and treatment? VTE is a major preventable cause of patient mortality and is listed on AHRQ as something that needs reduction. VTE does not only occur when a patient is bedbound in the hospital after surgery, but does occur many times after the patient is discharged home. There is also a knowledge deficit that has been studied and documented among patients who have been hospitalized and were at risk of VTE. In a study by Papula et al., patients were asked about what they would like to see in a way of education materials and the length of materials they would likely read or watch. Most patients have as their most preferred or their second most preferred topic of how to recognize signs and symptoms of VTE. 18% want to learn about prevention, another 18% want to learn about risk factors, and 16% want to learn about the potential consequences of VTE. Patients had differing amounts of paper education they felt they were comfortable reading. 199 and 197 felt comfortable reading 1 and 2 pages of information on VTE. 156 were comfortable with a 3-page paper, and 153 were interested in reading the guidelines from national clinical organizations on the subject. As far as video education, all 212 patients were interested in watching a video, but the length of the video differed. 110 were willing to watch 10 minutes or less, and 102 patients were willing to watch a video of 15 to 20 minutes in length. The person delivering the education to the patient was also found to be important. Here, how most patients who were polled for the study had a preference for their doctor to provide the information about VTE. As we know, the doctor has limited time that they can spend with each patient on lengthy education, and therefore it's imperative for doctors and nurses to be available to educate these patients. Utilizing multiple methods of educational materials for patients has been shown by Green and Bernhofer to increase retention of the information from 38% retention to 74% retention, which is a huge increase and will assist patients in making better decisions regarding medication administration, physical therapy, and assessing their own signs and symptoms of potential VTE. Therefore, I have to reiterate the practice recommendations are to evaluate vitamin D levels pre and post-operatively, add levels to the normal labs pre and post-op, and then supplement patients with vitamin D pre and post-op, especially those who have specific risks. Education should be provided pre and post-op, should be interdisciplinary, and utilizing multiple methods of educational materials according to the patient's preference. Risks for implementing these changes are few and can be mitigated by paying attention to the vitamin D level. Increasing education for the patients is never a risky thing. Patients always need education. Nurses on specific units that deal with postoperative and perioperative patients can be educated on the importance of reporting incidents of new DVT or PE to someone who is placed in charge of the information in order to determine the effectiveness of the changes. No ethical challenges were identified at this time. Change is never easy, but it is a certainty. Presenting recommendations on a change that is needed in a large institution such as the VA system is daunting, but we must stay the course for the improved care of our patients and veterans. Joshua 1:9 states that, "I have not commanded you. Be strong and courageous. Do not be afraid. Do not be discouraged, for the Lord your God will be with you wherever you go." Thank you for watching my presentation, and please feel free to look through the references for further information regarding how VTE affects our patients. Thank you.